Welcome everyone to the webinar today for the US Deprescribing Research Network. Today's webinar is from randomized controlled trials to population-wide scale-up using implementation science to get people deprescribing. This webinar is sponsored by the US Deprescribing Research Network with funding from the National Institute on Aging. My name is Dr. Jennifer Chia and I am a geriatric palliative care physician at the University of Massachusetts, and I will be your host today. I'm joined with my colleague, Dr. Ken Bookfar from Mount Sinai, who is going to host the Q&A after the presentation. And before we get started, I just wanted to cover a few technical details. Due to the number of registrants for today's webinar, we have placed the phone lines on mute to reduce the audio feedback. So unless you're logged in as a host or panelist, your line will be muted. However, we welcome and encourage audience participation using the Q&A feature of the Zoom webinar software. And when you'd like to interact with the presenter, just click the Q&A bubble icon on the bottom toolbar and type your question in the toolbox. If you'd like your question to be anonymous, you can check the anonymous box before sending, and the host will acknowledge the questions during the final 15 to 20 minutes of the webinar, although I also know Dr. Turner would like to have an interactive session, so please pipe up with your questions if anything comes up during the presentation. After the webinar, you will receive an email with a short evaluation survey. If you have any technical or logistical problems or questions during the webinar, we ask that you submit these directly using the chat to the co-host, Gabrielle Schiller, and chat privately. Please make sure that you are identified either by name or participant ID so that the webinar host will be able to troubleshoot any problems. We extend a huge thanks to the people behind the scenes that make this possible. Gabrielle Schiller at Mount Sinai, Jonathan Norton at Johns Hopkins, as well as Melina Sparn and now Rizzo at UCSF. Without these amazing behind the scenes people, this amazing work would not happen and these webinars would not be possible. So that's for our technical issues. I'm gonna now switch to introducing Justin. So Dr. Turner received a PhD from Monash University and his Bachelor of Pharmacy and a Master's of Clinical Pharmacy from the University of South Australia. Dr. Turner's research strives to optimize the safe and effective use of medications in older people with a specific interest in deprescribing. His passion for deprescribing comes from his frontline work as a pharmacist in hospitals, community, aged care, and policy sectors across Australia and the UK. Dr. Turner's research poses the question, how can we sustainably optimize the use of medications in older adults? To answer this question, he applies mixed methods to lead and evaluate local and provincial projects across Canada. Founded in implementation science, his research addresses the impact of health policy, patient engagement, and healthcare provider education on the reduction of potentially inappropriate medications in older adults as an individual, at the individual and both the population level. So I'm very excited to have you here. Welcome, and I'm going to hand it over to you. Thank you for being here.
Thank you for the introduction. I should have made that shorter. I'm so glad we're here today. It's a pleasure to be talking with USDen. It's an amazing opportunity to be here and talk about some of the work that I've been doing up in Canada. I'm very excited about how do we get evidence from randomized trials where we can show benefit of reducing medications or hopefully improving patient outcomes, but then how do we get it from there to a population level impact? That's something that's fascinated me for 20 years as a pharmacist and what really drives me in my research. So without any further ado, I will say I have no real or perceived conflicts of interest. I'm a researcher at the University of Montreal and I'm the co-director of the Canadian Deprescribing Network, but I don't have any drug companies wanting to give me millions of dollars to stop drugs. So alas, we move forward. Today I want to talk briefly, I guess first slide on appropriate medication use, talk a little bit about why I believe implementation science is the right way to be moving forward with my research, and then cover 2 trials going from Empower to the tapering trial and from Deprescribe trial to Safer Meds NL. I'd like to give some reflections on what I've learned in the last 5-6 years here in Canada doing this work, and then try and give a summary at the end. So before I give any talk on deprescribing, I like to have this slide first because I think it's really important to remember that medications, when used appropriately, control symptoms, get rid of pain, minimize harm from chronic diseases, prolong life, improve quality of life. Medicines used well are one of the best tools we have. However, not every medication is used appropriately. Dr. Beers back in the early 90s realized that some medications probably cause more harm than benefit. And from there grew the American Geriatric Society list of potentially inappropriate medicines, or the Beers list. And we know from research, looking at the pharmacy of research, that these drugs are associated with adverse drug events, side effects, falls, hospitalization, frailty, mortality. And what really intrigued me as a pharmacist is, if we've known this for 30 years and have good evidence, why is it that 37% of older adults in Canada are still getting prescribed Beers list potentially inappropriate medications? And why is it the same in the US? Why have we not changed our practice in the last 30 years? In trying to find an answer, I'm not sure if I'm reassured by this or worried by this, but there's some good studies that show it takes about 17 years to change clinical practice, to go from a great randomized controlled trial that shows statins improve mortality to actually getting the right people on statins can take 17 years. Probably the worrying bit for me, who's looking at deprescribing or de-implementation, is that that process seems to take even longer. And there's a great paper I didn't reference that's just come out recently showing there is probably a different behavior change technique that we need to use when we're thinking about stopping something that we do routinely, like prescribing, as opposed to starting something that we do. So maybe we need to look at behavior change models differently. As an example, an oldie but a goodie, back in the late 90s, about 30 to 40% of Americans didn't receive care according to the best evidence. And 1 in 4, 1 in 5 were getting inappropriate or unnecessary care. When I look at that now in terms of Canadian data, 37% are still using inappropriate medications. So the question for me is, how do we fix this? How do we get the evidence that these drugs are bad, or the evidence that we have an approach to deprescribe, or the evidence that deprescribing actually improves outcomes? How do we change practice? Because it seems we haven't done very well with that. Sean published this piece last year, which I thought asked the right question. It's who needs to do what differently, when and how, if we're to change prescribing. And the what differently, I think we've got evidence there, and the when and how is what I'm going to talk about a bit. But when it comes to the who, I want us all to think about, what's our role? Are we a prescriber? Do we need to prescribe differently? Do we need to write refills differently? Do we need to put indications? As Mark's been saying on Twitter, do we need to put an indication for why we're prescribing these medicines actually at the time of writing them, so that it's clear? As the pharmacist, do we just continue doing the refills, or do we pause and stop to see if it's appropriate? What's the role for patients? Do they have a say? Or do they just go merrily along with what we're doing? And where do policymakers fit in trying to change prescribing practice? So the reason I turn to implementation science is, for me, it's a little bit like this. We start over here on the left with evidence, whether that's pharmacy that benzodiazepines increase the risk of falls, or whether that's statins improve mortality. And we want to end up here in having that evidence base taken up by practice. But there's a huge gap in the middle, and implementation science tries to answer that gap, tries to say, what do we need to do to translate from one country to another, to translate the evidence from one medication class to another medication class, or from a very well-defined and well-controlled clinical trial to the very messy, poorly defined real world. So that's what implementation science seeks to do. And the official definition for implementation science is it's the study of the methods we need to promote the systematic uptake of research findings into routine healthcare practice and policy, and improve the quality and effectiveness of healthcare service and care, or in this case, to reduce inappropriate medications. Now, while this definition came out in 2005, I guess behavior change theory has been around since the 30s. In the 60s, we had the theory of reasoned action. We had self-efficacy from Bandura in the 70s. We had the theory of planned behavior back in the 80s. trans-theoretical model became sort of popular in the 70s for the 90s in smoking cessation. And then Susan and Mickey's work with therapeutic domains framework and behavior change wheel in the noughties. And the framework I'll talk about next, the consolidated framework, came out more recently. So when I started in implementation research, I went to a presentation in Ottawa and someone put this slide up and I loved it because it just summarized how I felt. The theoretical approaches of how do we take evidence and translate it to practice, there's a lot of theoretical approaches. There's hundreds. And really, theoretical approaches in implementation science are like toothbrushes. You're wondering, where am I going with this? Everyone has their own and no one wants to use someone else's. And when I heard that, it sort of made me feel better that I've got some I like and some that I don't get. And it really reassured me that everyone in implementation science is in the same sort of place. One of the ways to address this was to consolidate some of the theories. And the one framework I like that did that well is the consolidated framework for implementation research. Trish Greenhow over in the UK took about 500 studies and condensed it into a conceptual framework. And then this group took that framework and about another 18 or so to merge it into one framework. And the reason I like it is it's complex, but simple enough for someone like me to understand. So they say there's 5 domains to really consider when you're going from research to making a big behavior change at a provincial level, or it could be a hospital level. I know some of us work in hospitals. How do we put this little trial across our hospital? How do we take it from this ward to every ward? Some of us work in primary care. How do we change the primary care clinic we're in, or the primary care network we're in, or around the region we're in? Some of us work across provinces. We all work in different places. So how do we use this framework? And the one thing I wanted to say here that I thought I'd forget is it's important to consider this not only at my stage of taking evidence to practice, but when we're creating the evidence, when we're looking at creating the first trial to see if this works. We need these ideas in mind so that we can find out which of these were relevant in my trial, so I know I have to adapt them and make sure that that stays pivotal as part of the scale-up project. So the first one is the intervention, of course. What are the core components and which bits could be adapted if I'm changing from my geriatric ward to the cardiology ward? What can I adapt? What are the contexts, the outer settings of the country? Canada's obviously different to the US, different to the UK and Australia again. What about the inner setting? Is it the way my hospital is funded or the way that my community pharmacy receives funding? What about the individuals? Who are the key players involved in your project or the implementation, and what is the process? So to talk through that, I want to talk about the tapering trial, which I ran in Manitoba a couple of years ago. Tapering stands for the trial applying policy to eliminate or reduce inappropriate narcotics in the general population. In other words, can we address the opioid crisis? Hell, Canada's second only to the US in the amount of opioids we use. Opioid deaths overtook car accidents by 50%, and there was a lot of drama about opioids. This is before COVID came along. It still is drama, just COVID is worse. So that was the background. And I met with the Manitoba government and they said, what we want to know is what is the best evidence for reducing them? And I said, well, I have absolutely no idea. But Cara and the group here had just done the Empower trial, which is direct to patient education, shown here by sending a brochure to the patient and encouraging the patient to talk to their pharmacist or their doctor and hoping that the two talk together. So that was the evidence we went with. So the evidence of Empower trial, was about 30 community pharmacies across Montreal, and patients were selected if they were chronic users of sedative hypnotics, defined as more than 90 days and 125 days, over the age of 65, and didn't have dementia or on antipsychotics. Long story short, after 6-month follow-up, 5% in the control waitlist prescribed, but 27% had stopped the benzodiazepine after 6 months once they'd received this brochure that was couched on behavior change theory. So identifying, what do you know? What are the benefits of your benzos? What are the harms? How do you stop them? What alternatives can you do? Providing patients the right questions and information to help them start that conversation. So a number needed to treat of 4 to completely stop the benzodiazepine. We thought that was great. Did it work for opioids? We had absolutely no idea. So the tapering trial was designed to evaluate the effectiveness of a government-led mail-out of information that was directly to community dwelling adults who'd been using opioids for more than 90 days in the last 120. Now, if we go to CFA, there's a whole load of things to consider in the intervention, the source, the evidence. The one I'll highlight here, because of time, I won't talk about it all, but adaptability. We had this great brochure on benzodiazepines, and we managed to change it from French to English and include a whole load of statistics about why opioids was such a problem in Canada at the current time. CFA talks about getting to know the context. What about the outer setting, which they define as the political, social, economical? What are the contexts within which you're trying to do your project? Is it an entire country? Is it a state? Is it a neighborhood? Is it a hospital setting? What are the contexts on the outside? For tapering, there was an opioid crisis. It was in the media non-stop. Insurance companies had started to no longer cover people if they were on more than 200 morphine milligram equivalents per day. And there was an urgency. Statistics like this were being widely promoted that one life in Canada is lost every 2 hours. So we had a big drama about opioids. When it talks about what is the inner setting of your project, for this it's talking about the networks, communication, political or cultural contexts, and the structure. What are you trying to, how does your project fit in what's currently existing? In this case, I worked with the Manitoba government. There's a very well-defined hierarchy in government, which makes it quite easy or difficult to do research. The government was very motivated and they'd already done a number of things. They'd put together what was called the Manitoba Monitored Drug Review Committee, or MMDRC, which was a group of all the colleges, work cover, and people that had an interest in trying to reduce harm from opioids and other such medications. They decided from that group to give out free naloxone on every corner, it seemed. They'd employed a couple of physicians to give physician support about opioid prescribing, and they changed some rules on the way pharmacists dealt with codeine to try and get a grip on that as well. So a lot had happened in the inner context. When you're designing your trial or looking back to see did it work or not, because this framework is also good for reflecting, where did I go wrong, how can I get better? The knowledge, belief, self-efficacy, who are the key people you've got? Is it the nurse unit manager? Because she gets the whole team inspired. Is it that one doctor that just everyone looks up to and they'll walk over fire for that doctor because she's a leader or he's just dynamic and everyone follows them? In this case, we had 3 great individuals. The provincial drugs program branch manager, Trish, it's her photo there. She believed that she had access to data and we could use it in a way to improve health. The health minister wanted to try anything that was evidence-based, and the College of Physicians and Surgeons were on board because they realised there's a big issue of opioids in Manitoba at the time. The last step is to consider the process of implementation. You've got to define what is the process, how do we plan it, who do we need to engage with, how do we execute it, how do we evaluate it, what are the outcomes, which I love that USDN has got an outcomes committee, because I think that's some of the really tricky things. What can we get from big data, what can we get from people, and what are the meaningful outcomes to try and compare across trials? So this trial was a top-down approach, government led it, and it was very linear from getting provincial drug programs branch approval to ministerial approval through a million steps down to finally getting the brochures posted. So how did we do this trial? We went through that framework of how to get it to place, but how did it actually happen from the standard research talk? It was a pragmatic, prospective, cluster randomized parallel controlled trial. Step 1, we had to take the brochures we knew on sedatives that worked and the behavior change levers in there. We assumed the behavior change theory would be the same, so we just adapted it to opioids. The photo here is one of our lovely focus groups that we used to ensure that the right behavior change levers were there, ensure that people wouldn't stop the medication on reading the brochure, but it was very clear they needed to talk to their healthcare provider. It was clear what the benefits and harms were. It was clear that they had to gradually reduce the dose, but that wasn't necessarily their responsibility. In fact, we created an online tapering protocol because primary care doctors said it's so confusing. What strengths do they come in? How fast do we taper? So you can put in what the patient's on. Do you want to reduce every 1, 2, 3, 4 weeks? And it'll spit out a tapering protocol for you. Had to work with government to work out how do we identify people from pharmacy claims and how do we cluster randomize them. So to reduce bias of learning at the doctor level, we allocated patients to their family doctor, allocated family doctors to their clinics, stratified clinics into small, medium, large clinics, and then randomized within those strata. Long story short, we found about 4,225 chronic opioid users and randomized them to interventional control, with about 2,000 people getting wait lists and about 2,100 actually receiving via Canada Post a brochure about how to stop their opioids. Slightly more women than men use opioids in Manitoba. The average age was about 60, about a third were what we class as older adults over the age of 65, fairly even split between rural and urban in Manitoba. And while the recent guidelines had come out saying do not use more than 90 morphine milligram equivalents per day, the average dose was 155, sorry, with wide margins. In fact, we excluded people above 2,000 because we figured that maybe something else was going on there. So the results, drum roll, did it work? No. Cessation rates were the same across both. When we looked at, did we produce a greater than 25% dose reduction? No, they were the same about both. Now, I will point out here that we've had 11% cessation rate, which when we look at the original Empower trial, there was only 5% in the control group. So we're actually getting a fairly large background rate of deprescribing. When we looked at, did we reduce people below that recommended limit? No change there. But we did notice on subgroup analysis that men were more likely to reduce their dose than women. People who lived in urban areas were more likely to reduce the dose than those in non-urban areas, and younger people as opposed to the older people. So that made us hypothesize that maybe it made men go and see the doctor, which traditionally men don't do. Maybe urban areas have alternatives to drugs, or have drug tapering programs, or have something else you can do like physiotherapy instead of needing opioids. One of the interesting results we found in censoring the data for mortality was that about 90 days after sending out the brochures, there was a clearly statistically significant difference. You see the line separate here. This is mortality over days, being 0 days to 180 days, and cumulative mortality rate going up. While mortality was low in this population of chronic opioid users, there was a clear separation where the people who were the control group continued to die at a faster rate than those who were not, or who were in the intervention group, I should say. So what did we find? How do I summarize that? I summarized that it was actually possible. This was a win. We could take a randomized controlled trial from 400 people in Quebec and scale it up to a province at a government level. It was actually really feasible. However, we failed to produce a significant difference in cessation. There was a modest reduction in daily opioid use, particularly amongst the subgroups we talked about, younger adults, men, and those in urban areas, and reduced mortality. So we wanted to know why. Why didn't we achieve the endpoint we thought we would? So this is where CIFA can be used as an evaluation framework. The process of implementation was perfect. We couldn't have got it better, identifying people who were on the drugs and getting the brochure to them. The individuals we had involved were amazing. I haven't worked with a government who's like that dynamic. I've worked with a few governments who are dynamic, but that was the first one in Canada that just sort of said, yes, this is something that is our responsibility to improve the health of our citizens. And the inner setting there within government, from the process of evaluation, ethics, randomization, mail out, like posting thousands of brochures and collecting the data has been fantastic. Someone just asked, where can I access the opioid tapering schedule? If you go to deprescribingnetwork.ca, on our opioid page, there is a link there to the opioid tapering schedule. And in our brochure, there's a link as well in the PDF. So for me, evaluating where did I go wrong, it really brings me back to either the intervention was flawed or the context killed me. And I think maybe both. So the intervention, it really made us think, are the addictive potentials of opioids the same as the addictive potentials of benzodiazepines? Or put another way, people take benzos chronically for what reason? And people take opioids chronically for what reason? Maybe the whole underlying behavior change that makes us chronic opioid or benzo users means we need a different approach. Or maybe, tapering of opioids is slow. Maybe we just hadn't got there yet. When it comes to consider the context, how did I go wrong here? Well, they'd just brought in naloxone. So we looked at, had naloxone been dispensed more to the control group or intervention group? We found 2 dispensings of naloxone in 6 months. So obviously the free naloxone program was very successful at getting people to pick it up without needing prescription. The physician education support program, the College of Physicians and Surgeons in Manitoba, had an amazing work there, and the 2 physicians that were running that are fantastic. So I have no doubt that the extra support they gave clinicians helped all clinicians reduce opioid use. And that had been going on for about 12 months. So I think the low-hanging fruit, the people who didn't know opioids were harmful, had probably already been deprescribed. The alternatives availability in urban versus rural we talked about, I think that probably hampered our reductions in the rural areas. And behaviour change, as I mentioned, is the addiction potential different? In Empower trial, pharmacists handed out the brochure. In our trial, the government sent them a brochure. We had 1 or 2 people say, well, I'm not so sure I like the government telling me, hey, you shouldn't be on your opioids. And that was part of the work we did with the MMDRC to make sure that the wording of that message was, we're not stopping your drugs. We're not about funding, not about claiming, not about cost cutting. It's about trying to make sure you're on the right medications. So the limitations from this trial, generalizability. It's not often I can say this trial is generalizable to the population of Manitoba, because it was the population of Manitoba. However, whether it's generalizable to San Francisco for Mike, well, I'm not sure, because the settings are somewhat different. We don't know if everyone received the brochure that was posted to them. Only a handful, I think 4 or 5, got returned in the post undelivered. We don't know if patients understood the information. We don't know that we used the correct behaviour change levers. In fact, there's a lot of things we would love to have done on a qualitative aspect that, because of the novel approach being the first time the government was doing this as research, they didn't really want to scare patients by saying, here's a research study. In fact, one of the key things of the project was half the people got the intervention now, half got it in 6 months, to ensure everyone got education so that not a single Manitoban was left without education about their opioids. And we don't know from administrative data, picking on that last point, whether people actually take the opioids they're dispensed, or are they selling them on the street? We don't know that. So lessons learned, behavioural external contexts are super important. What else is going on around your organisation or around your hospital, within your hospital, that may impact your trial? The behaviour change techniques may be critical. If we're looking at deprescribing other drug classes like proton pump inhibitors, gabapentin, are the same behaviour changes needed that worked for sedative hypnotics? I'm beginning to think probably not. In some of the research I'm doing is showing that maybe we need different approaches. So in the few minutes I've got left, I'll talk 10 minutes about one of my other trials, which is called Safer Fentanyl. This is not a trial per se, it's actually government policy where the government of Newfoundland and Labrador has a funding project for community pharmacists or for pharmacists to fund professional services that they implement. And based off the Deprescribe trial, which I'll talk about in a second, they said, well, that's something that's an approach where pharmacists are funded to provide advice back to the prescriber, whether that be the nurse practitioner, the family doctor, the specialist, to say, hey doc, I'm dispensing this prescription. Maybe it's an inappropriate medicine. The reason is BizList says it's inappropriate. Benzodiazepines increase the risk of falls and fractures. Mrs. Smith's a little bit frail. She's had a couple of falls. Why don't we deprescribe and look at this as an alternative? They get paid to provide that clinical advice here in Quebec and in Ontario, but they don't in many of the other provinces across Canada. So the Newfoundland government said, well, let's see if we can do that. So I think I just shot myself in the foot in explaining this slide. Here's the brochure or the information sheet the pharmacist sends to the doctor, explaining why is the medication potentially inappropriate, what have they talked to about the patient, and what are the summaries that the patient's willing to do. So really priming the doctor to say, I've spoken to the patient about deprescribing, can you follow up with them? And by the way, I've sent the patient to talk to you about it. And on this side of the picture, they give them the education brochure. This one's been modified to show it's clearly sleep. We've got the clock and the mask, so it's definitely about sleep and their medications for sleep, and that's given to the patient with some conversation about why are you taking a benzodiazepine, is it insomnia, what have you tried, and go through the brochure. In the Deprescribe trial, which was done here in Quebec, led by Philip Martin, who was a PhD student with Cara, who I had the benefit of sharing an office with. This was a fascinating trial to watch him run. They had 34 pharmacies in, I'm pointing to the slide, you can't see me point, I'll use the mouse. 34 pharmacies in control, 36 in intervention, where they educated the family doctor and the patient. 43% had stopped their inappropriate benzodiazepine at 6 months. And here we see the background rate of deprescribing had started to increase across Montreal area. The word had maybe started to get out. But for one in every 3 patients where the pharmacist talks to them about stopping the benzodiazepine, they were able to stop, which is a great result when we look at what we spend on audit and feedback and other things where we get maybe 4 or 5%. And to have a 34% difference is huge. So taking that amazing result that was just sort of, the numbers were being crunched when I spoke to the Newfoundland and Labrador government and said, hey, look, you guys have a problem. 43% of older adults there take a PPI and 20% take sedatives, which if we look over here in the West Coast, no, it's 13% and 11%. Why do we have such a problem? Now, there could be many reasons, but one of the things they wanted to do as well, they were focused on appropriateness, on billing appropriateness of antibiotics, appropriateness of blood tests and ordering there. So they said, let's look at this as an appropriateness of care issue and what can we do moving forward? So they came up with the Safer Meds&L program, which runs in parallel to that policy change they had in funding pharmacists. Safer Meds&L was really a project to promote public awareness in an effort to try and educate healthcare providers and patients. So our goal was to reduce inappropriate use of sedatives and PPIs by about 20%. Back to that paper that Sean wrote, we want to go, how do we go about doing that? Who needs to do what differently and when? Is there any evidence to support this change? And how on earth do we implement it, or in implementation science, what's the process that we have to go through? So I think it has showed there's evidence. 43% of people stopped their benzodiazepine and deprescribed. So there's good evidence there that a collaborative approach with the community pharmacist, family doctor, and the patient works well. So who needs to do what differently? To answer that question, I decided pretty much everyone, and here's my collaborators on this project. We've got the Pharmacy Association, the Pharmacy Board, the Newfoundland and Labrador Medical Association, the College of Registered Nurses, CADATH is involved, Choosing Wisely, Newfoundland and Labrador, Institut for Patient Safety, I'm messing up my words here, whole bunch of people, essentially, including Canadian Association of Retired Persons. So we've got seniors and all the healthcare providers on board. And then we said, is there a process model? And the one I picked for this project is called Collective Impact. And it tries to show, for a time, I guess I'll just skip through, but we need to all agree that there's a key thing that we're trying to focus on. We need to agree that we can measure this key thing. We need to be able to, amongst all of those key players, do something that is going to reinforce each other. We need to talk to each other to make sure we're on the same page. And there needs to be someone who's trying to hold us all together. So we're not herding cats, is what I like to say. Make sure we're all moving forward together. So in terms of this trial, how did that work? Well, the common agenda, all of the stakeholders, when we first came together to say, how do you feel about being the highest users of some of these inappropriate medicines? They all agreed that they didn't feel great, and perhaps we needed to reduce the use of benzodiazepines and proton pump inhibitors. Focusing on those because Barb Farrell and her group and deprescribing.org had great deprescribing algorithms of how to reduce those medications. Our group out of Montreal had patient education brochures that we could use. So there was evidence of that and evidence of the brochures or the information from pharmacists to doctors. So there's good evidence on these drug classes that we can back up. We all agreed, let's measure pharmacy claims data because, hey, we can see if it's changing. Mutually reinforcing activities were agreed upon. The government said they were going to pay pharmacists to give the pharmaceutical opinions or the advice to the prescriber. Quality Care NL or Choosing Wisely NL was already planning to do audit and feedback to family doctors. So they said, look, this is perfect timing to align. Education was happening amongst the different associations, and we said, we'll bring along a public awareness campaign. We all agreed to have quarterly meetings to say, where are we at? What's the update? And the research team became the backbone organisation trying to hold things together. So how did that roll out? When it comes to talking about things working in a coordinated manner, we decided first step is we need to get the healthcare providers on board. We need to disseminate the tools, the Barb's deprescribing algorithms, our patient brochures, some of the online web, whiteboard videos that we've created to try and, in 3 minutes, summarize why should I deprescribe. That all had to get out first to the healthcare providers. The funding had to happen. The model behind there had to happen. That was a long process. Once that was out, we decided the public awareness campaign had to happen, collect some data, analyze it, feedback, and then move on to the next year to repeat again. Good old-fashioned plan, do, study, act cycle. So the public awareness campaign, I'm not sure if any of you have seen it. I know in the States you have direct-to-consumer advertising for drugs, which is an interesting policy. We decided to take that, flip it on its head, and do direct-to-consumer advertising against using drugs. So some things aren't meant to be long-term. Dear heartburn medicine, we've been together for nearly a year. It's time to move on. We launched that in February for Valentine's Day. We've got some about the harms of sleeping pills. We had some TV commercials here with patients, pharmacists, doctors, and nurse practitioners, all promoting appropriate use. And we flipped our head when COVID came along to have a more embracing campaign about, is counting sheep not working? Here's some safe alternatives of what to do. And this went on TV, radio, YouTube, social media, newspapers, internet, back of the bus. Ice hockey or hockey here is big, so we put it up at hockey rinks. We put it anywhere we thought we could and spoke to all the seniors groups we had engaged. So it was really great. What were the outcomes? We're trying to measure the prevalence of inappropriate medication use across the province. It's going to be interesting. So we're using an interrupted time series analysis, data from dispensed data in pharmacy really got upgraded in 2017. So I'm fairly confident in the data from 2017 moving on. So we have a little bit of historical data to compare against what's happened now. We have the ability with this to look at the cumulative effects. So what happened when we did the healthcare provider engagement, what happened with the added benefit of students, what happened with, we got pharmacy students, we forced them into cheap labour as part of their placement to promote this integration, what happened with the public awareness campaign, and look at the cumulative effects. And understandably, when COVID came along, everything dived because the system was overwhelmed. So it's given us a great ability to look at what has changed things over the timeline. And it allows us to look at sex, age, and geographic location as well. When it comes back to implementation outcomes, we thought that was really important. So we're trying to work out what were the barriers and enablers and what are the practice pearls of frontline healthcare providers. We've done some qualitative research there, which we're in the process of writing up, saying, how did they implement it? Because I don't believe what I hear, which is there's not enough time, there's not enough money, I don't know how to do it. I mean, yeah, that's true on all three, but I don't think really, as one of the participants said, she goes, let's be honest, if I really want to deprescribe, I will. I do what I think is the most important thing in the day. So how do we get deprescribing to be the most important thing of the day is what I'm really interested in at the moment and how I'm approaching our analysis there. The collective impact model of bringing everyone together to agree on a problem and how we're going to work together is new in health research. It's been used in education and other things before. In San Fran was one of the good studies. So we're trying to assess, does that work in this setting for primary care health change? Quality Care NL, or Choosing Wisely Newfoundland and Labrador, is doing an evaluation of their academic detailing, their audit and feedback to doctors. Did they manage to reduce PPIs? We're doing a population survey too, which I think is my next slide, and we're looking at how widely did pharmacists embrace the new professional service? Because let's be honest, we all know just because you pay for something, it doesn't mean someone's going to do it. So is the we need more money actually enough of a carrot? Was there enough money offered, or was the system still under stress that it's just not going to work? So the other evaluation framework from implementation science that we're using is REAIM, to look backwards and say, what was the reach and adoption? And you'll see here a map of Newfoundland and Labrador. And this is where we've either had events, sent materials, engaged with pharmacists, engaged with doctors, engaged with community organisations, held events with seniors, did mall campaigns, put advertising on buses or ice skating rinks. We tried to go everywhere. And to see if that worked, we're actually doing a telephone survey to try and find out, did people aware of the campaign? Have they changed what they do? So the limitations are wearing on right up to my time. It's an observational project, it's not interventional. So there's no clear-cut control. It makes the analysis a bit different. The intervention is difficult. Everyone was doing something different. Quality care was doing things with their audit and feedback at a different time to the education we were giving to pharmacists, at a different time to the education done to nurses, at a different time to the public awareness campaign. So it's hard to say one thing that was done, which means there's multiple contexts. If we consider it from the CIFA framework, there's multiple contexts that could be influencing this. And political contexts have a big influence, both the big P and little p politics, which I won't talk about now. Our implementation outcomes are proving to be fascinating. I'm really loving this part of the research to see what's motivating people to implement deprescribing and take the evidence-based research and scale it up, and what's hindering them from doing that. But I'm aware that our sample size is small, and we've probably got people who are, like me, believers in deprescribing, though not all of them were. So that our results we need to take with a grain of salt. And awareness to public awareness campaigns difficult. So in summary, I'm going to finish on time. Inappropriate medication use is really common, it's really costly, and it's something that we need to address. The evidence about inappropriate medicine use has been around for 30 years, and yet we haven't made any difference. So improving that, or reducing and deprescribing inappropriate medicines, is going to need behaviour change. It's going to need it from all of us, prescribers, pharmacists, patients, policymakers. All of us need to get involved, and I think collective impact is a great approach to bringing us together on this important topic. What I like about implementation science is that it provides guidance of how to move from the clinical trials of something that's worked, or the epi trials of drugs that are harmful, and how to try and implement that in the system, whether that's our hospital, whether that's our primary care network, whether it's a province, a state, or hell, why not go for the whole country? Implementation science needs to start with data and end with data, but have a very structured process to answer what goes on in between the two. And my last question that I want to pose to you, for those who are designing trials, those who are running trials, those who are evaluating trials, or maybe even scaling them up, have you looked at the design or implementation or evaluation of your research through an implementation science lens? Have you looked at a framework to work out what are the outer contexts, inner contexts, the personnel involved? What can you adapt and what has to be kept really as a core part of the intervention when you do your research? I have a couple of slides of references in case you don't believe anything I'm saying. Want to put some faces up here. Obviously, people have funded me from my tax and CIHR, and the government people have been great, none of whom I could have done this without, and my research team. And I think that means I'm back to you, Ken, for any questions.
Great, thank you so much, Dr. Turner. What an amazing logical journey, and ending with a project of incredible scope across the whole province. Just a reminder to the audience to type your questions into the Q&A. And we do have some questions coming in. While we're waiting, I have a question, which is, do you know of any efforts to incorporate deprescribing at the learner level? So in other words, starting early before they learn to prescribe inappropriately, because I feel like that would probably be more efficient than trying to get people to learn how to deprescribe.
I do. I guess first off, I'll shout out to Barb Farrell, who's one of the key members, who core executive of the Canadian Deprescribing Network, and she's the chair of our healthcare provider committee. And that committee has, for the last number of years, been trying to work on a white paper, which I'm the weak link at the moment. I will confess I have it on my desk to review, and I haven't, which really is trying to promote how do we educate not only as undergrad, but also when we're getting that, hey, I now have prescribing license, let's go, and the more senior of us, how do we review our practice? So we have a position paper coming out on how we believe education should be taught. So that's the watch this space imminently. The other side to that is from my practice. Yeah, I started teaching deprescribing in pharmacy school back at the University of South Australia 10 years ago, and it was like, wow, we'd never thought of this. And back then we didn't have Barb's evidence-based guidelines. It was still my clinical gut feel of what did I learn on the wards, how did we learn it? So the how to teach it is something we're still working on. But the multi-D approach I think is fascinating. Professor Andy Gilbert, who was one of my mentors in appropriate medication use, we were talking about this over a beer at his beach house one lazy Saturday afternoon and said, oh, actually, we should look at other healthcare providers. And he ended up talking to the physiotherapy school about appropriate use of non-steroidals, and we had an amazing result there with young physiotherapists going, oh, we didn't even know this was a problem. So I think the training of people from the younger group upwards is a vital bit. And Barb's just said she's the co-chair, not the chair. Lalitha Wilms and her are both co-chairs, and others on the committee are producing the position paper. So thank you, Barb. Sorry, yes, there's two co-chairs on the committee. But great question, Ken. I think if we look at the behaviour change of how to stop prescribing, I think what we learn as it becomes a reflex, we learn that in our junior years, and I think that's where we need to change the reflex to prescribing.
Right. Okay, great. So we have a question coming in, which is, when do you give up on trying to obtain consent for a taper? Or I suppose, when do you, there may be some issues around consent, especially in let's say in research, but why don't you go ahead and take that one?
Thanks, Colleen. That's a tricky one. I guess anything we do with patients, we need patient consent, whether that's starting a medication, stopping a medication, dispensing the medication, re-prescribing it, renewing the prescription. Deprescribing should be patient-centered. For me, I'm not sure where you fit in there. If it's you say it's the only medication she'll accept from her GP, I'm assuming that's a general practitioner or a family doctor. I would be trying to work with the family doctor to ascertain why. I know that I say I don't like benzodiazepines and the risk outweighs the harm in most situations. Is it for primary insomnia, or is there generalized anxiety disorder and this is the only thing that works to give her quality of life? I think when I look at it from a pharmacist perspective and I see it on the drug chart or in the nursing home, it's easy to pass judgment without being patient-centered. So I would approach there and work with the GP. In terms of consent, if it's a person on a dementia ward, if they don't have the ability to consent, are their family happy to consent? And I've definitely done that in clinical practice before. I had the family consent to a slow taper on behalf of their older relative who's living in nursing homes. And is it, when I look at my kids and say, look, good example, stop running, because it's icy outside in Montreal right now. They're not going to stop running. It's like, so what do I do? So stop running. Why don't you skip? Like, oh, okay. And it gets them out of running. Yeah, skipping's probably just as stupid, but it slows them down and it's funny, but you need to give them an alternative if you want them to stop running. Same with diazepam. If it is for insomnia, are we able to get that person cognitive behavioral therapy for insomnia, get them set up with that, get them actually learning how to sleep, and then go through the taper there? So I think your question depends on more detail on the patient, but it needs to be patient-centered and work out why they're on it and why they're reluctant to stop.
Great. We have a question in. If you were to redesign your deprescribing intervention from class-specific to inclusive of all medications, what would you change? How would you do it differently?
Which intervention? Can I ask that? While I'm waiting for that to get put up, I guess I'll answer. If it's patient awareness, what we learned, and I'm going to cheat here because it's something I'm working on at the moment, is because Cara was mindful enough when they did the Empower trial to go back and ask patients, you know, once you read the brochure, what did you learn and what did you change activities and why? The things that motivated people to talk to their healthcare provider, their doctor, or their pharmacist about their medications in the Empower trial was they suddenly learned the drug wasn't helpful, didn't help them sleep, or it was new information that they were harmful and increased the risk of falls and fractures. The patients that learned that suddenly had an aha moment of, hang on, what am I taking this for? And that's what drove the conversation to the doctor. And then having the alternatives, there was a peer champion page which shows, someone like me was hooked on benzos and they stopped them. Some of those other behavior change supports and nudges are in there. But that's what patients said they came up with. So if I wanted to adjust my patient approach to a general deprescribing approach, I guess it goes back to the way we're running our public awareness campaign at the moment with the Canadian Deprescribing Network, which is some medicines have more harm than benefit. As you change, your medicine should change too. As you get older and you change, maybe your medicine should change too. Those are the wording and the messaging that's come out, and I know Barb did some great work coming up with an advertising group, how to promote deprescribing. So if I was working at how would I change my current research, that's what we're doing in Newfoundland and Labrador, trying to drill down on what are the, for proton pump inhibitors, the public awareness campaign there was these drugs that probably aren't that helpful. Why don't you review why you're taking them? And the healthcare providers on our stakeholder group are definitely saying the approach now for sedatives should be these things cause harm, and we're really trying to focus on that to start the conversation. And Safer Medicine overall is trying to raise public awareness, but we didn't know how to do it as a general approach. We're doing one class at a time where there's good evidence. I hope that answered your question.
Right. I mean, in geriatrics, what we find is, when we're addressing somebody on multiple medications, 10, 15 or more, is there an equivalent behavior change, or what behavior change techniques might you need that are different from class specific, and would a mailing be part of that, and what would the mailing say? I think it's kind of the
that's the question. Sorry, now I get that better. I was fortunate Australia pays pharmacists to work with family doctors and spend an hour in a person's home to go through the medicines with them. You learn a lot in 60 minutes about what they value with their medicines. You also learn a lot that we don't often ask patients, why you want it, is this meaningful for you? And actually trying to ask people what is meaningful for them and do their medicines meet that. The goal of my treatment is to have quality of life, and I don't care if the quantity is not there, or do our medicines reach that? So the mail out there, I think, is vastly different again, saying, where do we approach that? And CPSI, Canadian Patient Safety Institute, has put a lot of work into the 5 questions for your medicine. Is this safe? Do I need to be on it? What do I know about it? And it's questions to try and prompt people to ask. So if I'm looking at polypharmacy, that's the big place I start. What do I know about the benefits, the harms, how long I need to take it, what are the alternatives? Those are where I start if I was doing a initial deprescribing thing. When it's at a patient level, I normally ask them what drugs do they not like, because they're easy to stop. Yeah, no one likes the statins, but maybe they're the ones providing benefit in the younger adults. And what drugs are causing side effects, particularly in geriatrics. Are they causing the geriatric giants? Are they causing falls? Are they causing cognitive problems? Hey, we can go straight for the anticholinergics because, wow, you've got memory's causing you some problems. Well, this drug might not be helping your memory, and it's probably not stopping you from peeing either. So why don't we get rid of it for that? And taking a patient-centered approach. So the short answer, the big questions like what the 5 questions that Canadian Patient Safety Institute promotes, and there's a whole load of 5 questions. National Prescribing Service in Australia has some similar ones, and I've seen Choosing Wisely in the US with similar ones, is probably the approach I'd take if it was to just start a conversation about deprescribing.
Thank you. Great, well, we have a few more minutes, so please type your questions in. We have another kind of clinical question, which is, if you recently read that a major depression may be a possible reason for use of high-dose steroids, and the worry over unmasking psychiatric disorder when tapering. centrally active medication?
I'm not overly familiar with using
Okay.
morphine for a major depressive disorder. All of the work that I look at in tapering opioids is do it slow. 5 to 10% is the recommended level here. And if there are psychiatric issues, I would do it in collaboration with the psych people. There's probably better drugs for treating major depressive disorder than opioids would be my guess.
Before we finish, for the US Deprescribing Research Network, can you translate keener for us? What is a keener?
Ah, what, did I say that or write that?
It's on the slide.
The keeners, yes, I said deprescribing. People who are really enthusiastic, people probably listening to today's call. So when we do the qualitative research in Newfoundland and Labrador saying, hey, the government's paying pharmacists to deprescribe, we want to find out your thoughts on it and how you've managed to get this to work in primary care. We advertise through the Medical Association, Pharmacy Association, Nurse Association, Nurse Practitioners Association, social media. You're probably not going to get too many people to say, I think it's a stupid idea. You're going to get those, that's great. So we're aware that some of the feedback we get is from people who are keen or enthusiastic about the project. Having said that, we actively tried to find people we knew didn't like it and were not involved, and got some of them involved just to give a rounded picture to the qualitative story we were getting.
Great, thank you very much.
I was unaware that was not a American term, sorry.
Okay, great. Well, thank you again. This is fantastic conversation. I'm going to turn it back over to Jen, who's going to do a wrap up.
Thank you, Dr. Char. That was just terrific and so impressive. Thank you so much. Not just for the presentation, but for all the work that you're doing. Canada should thank you there. So I want to thank everybody who has attended today's webinar. The recording of the webinar is going to be posted on the US Deprescribing Research Network website. Please don't forget to fill out the short evaluation survey that's going to pop up right at the end of this webinar. And don't forget to put on your calendar our next webinar, which is going to be on Tuesday, April 13th at 2 o'clock Eastern time. It's going to be with Ms. Carol Lee Thorpe, Ms. Laura Trejo, and Dr. Phyllis Willis, and they are going to be presenting the US DEN's version of what does stakeholder engagement look like, and what does it have to do with deprescribing and all this work. So please register for that webinar through our website. And thank you for your time, and thank you for being here, and have a great day.
Thanks, everyone.
Thanks.